Assalamu alaikum and very good evening to everyone. And I welcome you to on the platform of Society of Emirates Society of Internal Medicine. And I thank you all for taking your time out of on during the weekend to participate and listen to our two esteemed speakers.
The recording in progress.
As you are well aware that today's topic is Am I listening my echo? Is something wrong with listening my echo? No. Yes, so today I think there's some technical issues here.
You can go ahead again, Dr. Manish.
Yes, okay. So as the topic is today is we'll be discussing about the venous thromboembolism, and we have got two very esteemed speakers, one from Dubai, one from Abu Dhabi. And we'll be discussing a very important topic of thromboembolism. As we are all aware that the venous thromboembolism risk in the community as well in the, especially in the hospitalized patients is quite high. And if you talk about the pulmonary embolism, around 10% of the mortality are associated with the pulmonary embolism. And the important thing is that a lot of these patients who die of pulmonary embolism, they are either asymptomatic and without any preceding sign and symptoms. The other important aspects of VT, you can say, is that they are associated not only with the acute morbidity and mortality, but they've got a long-term complications like post-thrombotic syndrome in case of the deep venous thrombosis, and in case of the any apart leading up to the pulmonary hypertension, especially chronic, pulmonary embolism, pulmonary hypertension. So to discuss all these, important aspects of the treatment and the complication related to the pulmonary embolism as well as the use of NOACs in cancer-associated thrombosis. Cancer is another important risk factor for thrombosis. So now we have got two esteemed speakers. First of all, I will be requesting Dr. Hasnain Al-Shakriji. He's a consultant internal and acute medicine, certified UK certified board internal as well as the acute medicine board. He's working as a consultant acute medicine in Medical Clinic Parkview Hospital. So he'll be talking about can we better manage VT and maybe talking about the pulmonary embolism. So over to you, Dr. Hasnain.
Thank you very much, Dr. Nias, for the introduction, and thank you very much for the committee and for inviting me to this webinar. Delighted to be here. So I'll share my presentation. I will be talking about the question is, can we better manage VT? And the answer is yes. I think we do believe that there is a lot of area of improvements to enhance and better manage the VT. The topic is big, so I'll be focusing mainly on the pulmonary embolism. There is obviously other aspects like the DVT and the outside the unusual site thrombosis. These both require other, let's say, other talks. Sorry. So these are my learning objectives. So I'll give an overview of the diagnostic pathway. That will be very brief. Just a reminder, focus more on the risk stratification, which I think is an area, a big area, which do truly believe it's probably or underestimated / not properly done in some aspects. As well, I will be talking about treatment, duration of anticoagulations, and a brief about the risk of VT recurrence. I'll start with giving a common case, which probably most of us have seen. Most of us who works in internal medicine and acute medicine or in emergency medicine will see some similar cases. So young 45, fit and well, came in with a progressive shortness of breath. She had a syncope on the day of admissions. Her observation as recorded, blood pressure is upper side, bit tachycardic, lower side saturations, and slightly tachypneic. examination as recorded, no trouble, no surgery, no previous VTE. So the questions which I will hope I'll be able to answer throughout the presentations is, and these questions which probably should come to our mind whenever we assess patients with a VTE, which is what's the appropriate investigations to arrange, what is her or his or patient's mortality, the 30-day mortality for the patients with a PE if they have a large PE. What's the immediate treatment to start if there is evidence of RV strains or if there is no evidence of RV strains. If no trigger identified, what's their recurrence rate in the first year, and what's the duration of anticoagulation? And I will try and answer all of these questions throughout the presentation. To give you an overview of the size of the problems, pulmonary embolism is a major health problem. The incidence can be reached up to 1,700 with case per 100,000, and this is going up with age. And as highlighted by Dr. Niaz, the mortality is very varied. The small tend to be low mortality, but the massive PE, they have a very, very high mortality rates, reaching up to more than 60% in certain circumstances. Worldwide, it's relatively common with the estimated loss 3 million per year worldwide. So it's a worldwide, let's say, conditions. Middle East not free from this, as well as a quite reasonably common conditions within the Middle East. With aging populations, the incidence of VTE is increasing, and as you can see here from the chart, it's increasing hugely after the age of 50 to 60, and it goes up as the age goes up. Diagnostic, all of us hopefully familiar with the Wells scoring. That's the first point in any diagnostic pathway for pulmonary embolism, is to estimate the clinical likelihood or clinical probability of a pulmonary embolism using a very validated score. Has been recommended by most of the guidelines to use it as a first tool in the diagnostic pathway. And after applying these points, we will have a clinical probability of a likely or an unlikely PE. In the event where you have a very high clinical probability of a PE, the immediate investigations will be, you start with the, let's say, with the imaging with the CTPA. While if the low or intermediate clinical probability, obviously your diagnostic pathway will go through using the D-dimer. So D-dimer is still an important role in the diagnostic pathway. And obviously if the D-dimer test is negative, then you would have excluded the PE in the low to intermediate clinical probability. This is all based on a good evidence from the Christopher study, where the patients, when they have a low Wells score or with a PE unlikely score, as you can see here, if the D-dimer is negative, you have a good degree of evidence that you will not miss let's say, pulmonary embolism. Their 3 months risk of a score is less than 1%. So if you have a patient with low to intermediate probability with a negative D-dimer, you can reassure them that's extremely unlikely to be the PE. Obviously, if you have a clinical probability of PE, your diagnostic pathway change. You don't use a D-dimer as a tool, and you go ahead with the scanning. What about in pregnancy? So in pregnancy, previously we used not to use the D-dimer at all in the pregnancy, but actually, in fact, there has been some more and more evidence to suggest that you can use it as well, again, in the low and the intermediate probability to exclude pulmonary embolism, but not to help in any diagnostic pathway. So the SCE guidelines does suggest that you can use the D-dimer as a ruling out basically diagnostic for a PE to avoid exposure for unnecessary radiations. But again, you have to apply the clinical probability. So if I have a patient with the pregnant lady with the high clinical probability of a pulmonary embolism, then an imaging would be required, as highlighted here. And the imaging intend to be depending on the availabilities in your let's say health organization. And depends on, for example, X-rays is a marker. Before using any CTPA or a VQ scans, is Doppler bilateral is the first tend to be line. And if this is negative, then you would have to consider either a CTPA or a perfusion only scan. If the X-ray is abnormal, then a CTPA will be the next step in the investigation. But if the X-ray is normal, you can consider a perfusion scan. Thus, in the event of the let's say pregnancy treatment, I will be talking about it later. Risk stratification. That's my main part of the, let's say, presentations. Hopefully, you're all familiar with this classifications that the ESC has put. So the first line, when you once you've diagnosed a pulmonary embolism, it's very important to risk stratify the patients into whether they have a low likelihood of mortality, intermediate mortality, let's say, risk of mortality, or high risk of mortality. And as well, the new evidence suggests that we use as well intermediate low and intermediate high. The differences is predominantly, as you can see here, if there's any patients with hemodynamic instability, then their risk of early mortality are extremely high, and this is reaching more than 15%. They fit these criteria if for example, they have predominantly hemodynamic abnormality, they have a high PESI score, they have evidence of RV, let's say, dysfunction either on the echo or on troponin. They have as well elevated cardiac troponin on their blood test. The intermediate, they are in two groups. They can be low intermediate, or they can intermediate high early mortality. That's based basically whether they tick the two boxes of evidence of RV dysfunction, and again, that can be seen on echo scan or a CTPA or on the BMP, and evidence of elevated cardiac troponin. While the intermediate lows tend to be having only one, either the evidence of RV dysfunctions or elevated BMP or elevated troponin. The low mortality risk are the one who have a less than 1% risk of mortality, and these are tend to be the patients with simplified PESI score, which I'll talk about in a second, of 0. This is a simplified PESI score, so that's a validated score to be able to stratify the patients whether they are at a high risk of mortalities or lower risk of mortality, and as well as help us to identify the patients who we can safely discharge from, for example, from the ER, or we can safely discharge after observations of a period of time without a need for a long let's say admissions over a couple of days. They could be staying overnight in the hospital, or they can be even discharged direct from the ER if they fit all of these criteria, or if they have a very low simplified PESI score. Why it's important to risk stratify. So risk stratify not only help in disposal of the patients, so whether you decide to treat the patients as an inpatient or whether you decide to treat the patients as an outpatient, but as well to help us to know and decide certain types of a treatment which might offer for selected group of patients. For example, all of us hopefully we know that any patients with a large pulmonary embolism with the hemodynamic instability, their first line of the treatment doesn't tend to be there. Let's say that you might consider thrombolysis. But before we consider that, I thought to give just a definition of the massive PE. Massive PE can be defined as either the patients have a cardiac arrest, or systolic blood pressures of less than 90, or there is evidence of end organ hyperperfusion. They have cold, clammy, oliguric. They have a very, very high lactate. The systolic blood pressures need to be more than 15 minutes. Bear in mind a drop of 40 millimeter mercury, irrespective of whether it is above or below 90, is as well counted as a massive PE. So if you have a patient you observed and they have blood pressures of 150 and then suddenly deteriorate and their blood pressures drop to 100 or 90, 95, that might still fit the criteria for a massive PE. So a drop of more than 40, obviously excluding any other causes like arrhythmia, sepsis, or hypovolemia. This we see it in up to 10% of patients with pulmonary embolism, and as I've highlighted before, they have a very high mortality rate reaching up to the 60%. Their first line treatment, as we all aware, is a full dose thrombolysis. Unfractionated heparins will be the first as well, the preferred options of anticoagulation to start with. This is tend to be a TPA with a bolus of 10 milligram followed by 90 milligram over 2 hours. There is a risk of major bleeding. There is a risk of intracranial hemorrhage as well, but overall it's outweigh normally the risk of the risk of death from pulmonary embolism. But each individual, obviously, you have to check that there is no contraindications for thrombolysis. If obviously there is a contraindications for any reason, then the treatment should be considered as a surgical embolectomy or of a catheter treatment. That's the second basically line. This has been recommended by the ESC, European Society of Cardiology, and as you can see, that systemic thrombolytic therapy is a 1B recommendations. And unfractionated heparin should be considered for these patients at the initial start of the treatment. What about this group, the intermediate high, intermediate low? There has been, these are what we label them as submassive, which are these patients with evidence of RV dysfunction or evidence of myocardial injury, either elevated troponin, elevated BNP, large clot burden on the CTPA, but they are not hypertensive. Again, they have a mortality and adverse events is variable between 3 to 25%. 25%, and as Dr. Nayaz highlighted at the beginning of the presentation, what we worry about these patients is the complications, secondary complications. So pulmonary hypertension being specific, or CTIF being more specific for these patients. Important to identify again these patients. There has been a few studies to try and identify them, and the most recent and the most again validated score is what we call the BOVA score, where we can identify which of these subgroups have a high intermediate or low intermediate risk of mortality. Again, what to help us to know is duration of for how long you keep the patients under observations. You have to closely monitor the patient, for example, if they have a high intermediate risk of mortality. You might consider treatment with thrombolysis, which I'll come in a later let's say slides. So I think after identifying first the patients, if they have massive PE, if they are hemodynamically not stable, if they are stable and they have intermediate, let's say clots, apply a BOVA score where we'll be able to identify if they have a high intermediate or low intermediate risk of mortality. Simple to apply. It's basically blood pressures, elevated cardiac enzymes, RV dysfunctions, and tachycardic. And you can see from the charts the risk of mortality as the points goes up, as the stage goes up, they have a much higher mortality and higher risk of complications. With using the POVA score and with you identifying the patients who, for example, have an intermediate high risk, the questions comes, okay, do we apply the same treatments or do we consider them as a thrombolysis? We consider them for thrombolysis. These are patients who have submassive PE, no hemodynamic compromise, but they have evidence of RV dysfunctions. They have evidence of right-sided, let's say impairments. The PETHOS studies looked at that, and they basically double blinds two group of patients with either unfractionated heparin infusions or thrombolysis with a TNK and followed by unfractionated heparins. They overall they showed a better improvements in terms of hemodynamics, but much more at the expenses of much more higher let's say bleeding risk. And as you can see from the numbers here, is that basically it's all-cause mortality is higher in the cases of no anticoagulations, but they have a much more higher incidence of hemorrhagic stroke. So the conclusions from the studies is a concept has been highlighted, which is the risk stratifying patients, the normotensive, that's anticoagulations or thrombolysis can be considered, but obviously at the expenses of a high risk of, let's say, hemorrhagic stroke. As of yet, because of that, it has not been recommended. So most of the guidelines suggest not to consider thrombolysis for the patients for the, let's say, hemodynamic compromise, except in a very, very selected patients where you can consider if they have a very, very low risk of a bleeding. However, another small trial, which is the MOPED trial, have used the principle of half of the dose of thrombolysis. So this is using 50 milligram total instead of the 100 milligram of a TPA. It's not a strong, not a very strong, not a very big study. So it's a small study. However, with this small study, it does show that there is evidence, as you can see here, that's the patients with pulmonary hypertension, much less in the group of they received half a dose of thrombolysis comparison to the control group, which is the patient basically received a standard treatment of anticoagulation without half a dose of the thrombolysis. Again, the recurrence and the mortality is more or less basically better in the group where they received half of the dose. So the problems, as mentioned earlier, this study is a small study. There is some ongoing studies to look at the bigger number. It's a single center study, but it's one to highlight that you might, in a very selected group of patients, think about considering thrombolysis if they have extremely low risk of let's say bleeding. Half of the dose anticoagulation can be in a way considered. Again, this is have to balance it with the bleeding risk. The ACC, the most recent basically guidelines, is obviously for one of the massive you have to consider, but the high risk submassive does show some improvements in the hemodynamic, but the evidence still not very strong, but something you have to basically think about and consider. What about the low risk? Low risk are the mortalities, as mentioned to you, is very low, and that's basically the group which you can consider early discharge, or even in fact treat them discharge from ER without a requirement of admission. So the most important thing, as just to re-highlight again, is any patient with pulmonary embolism, we should do a risk stratifying using a simplified BESI score. We should consider a troponin, BMP, or an echo scan to evaluate their RV or evaluate their mortality. We can, if they have intermediate risk of let's say mortality, another score can be applied, which is the BOVA score. That's about the risk stratification. I'll move on to the third objective, let's say objective in the presentation, which is the treatment and duration of anticoagulation and the risk of recurrence. We all aware anticoagulations is the main treatment basically for let's say pulmonary embolism. Many trials now we are more familiar in using let's say DOACs. These are the most available one: apixaban, rivaroxaban, dabigatran, and edoxaban. There is no direct, let's say, trials against any of these. So there's no possibility of comparing one DOAC against another. They are all seems to be superior and favors NOAC in comparison to the standard of warfarin treatments. Their risk of bleeding seems to be as well lower comparison to warfarin, as you can see all of the charts. To be aware, as I mentioned, there the availability in the market are rivaroxaban, apixaban, edoxaban, and dabigatran. No direct studies to be able to compare, but there are some minor differences in the population that's been used in the studies. And as you can see here from the charts, for example, in the edoxaban groups, they've used it a lot in the extensive and massive PE here, to a lesser extent in the for example in the rivaroxaban. As well, I thought to mention edoxaban require 5 days of enoxaparin to start with, or 5 days of low molecular weight heparin, while the rivaroxaban and apixaban doesn't. Advantages of each have its own advantage, and each has disadvantages. I don't think there is a drug which fit for all patients. I think we should be all familiar with the advantages of each and disadvantages of each. I'll give my own experience. For example, rivaroxaban need to be taken with food. Otherwise, the bioavailability is affected. Initially, it's twice a day for 3 weeks, then followed by once daily. Edoxaban does have requirements of using low molecular weight heparins for 5 days before using edoxaban. It's once daily. Apixaban is twice daily. Rivaroxaban is primarily absorbed from stomach, so from the small stomach, hence the necessity of the meals. Rivaroxaban mostly studied as well. There's a big cohort of patients with overweight, which I think the strongest evidence in using it. Edoxaban, that's good, have a good evidence as well for patients frail and elderly, in the cohort of the studies that they've used. Same thing here. It's just for the extensive PE, as you can see, a big use of edoxaban. What about the duration of anticoagulation? So we know, as a rule of thumb, minimum 3 months of anticoagulation is required. Then you will have to identify whether the patients have any reversible risk factor or no reversible risk factor. If they do have a major transient reversible risk factors, then tend to be the recommendations in 3 months. This is based on their risk of recurrence of VTEs and tend to be more small. While if they have a persistent risk or a minor risk, then an extended duration of anticoagulations need to be considered. When an extended duration of anticoagulation considered, you have to balance 3 items. That's a patient's preference, a bleeding risk, while they are on anticoagulations, and the recurrence recurrence rate without the anticoagulation. Risk of recurrence is variable. So the patients where no cause identified is roughly or no major let's say risk identified. Roughly in the first year there is risk around 10% recurrence. Thereafter, it's a cumulative risk where every year around additional of 5%. In around 5 years, they have around 25 to 30% risk of VT recurrence. But how can we identify the patients who are at higher risk of recurrence? Again, various things that you can use, the mode of presentation. So if they are obviously no provoking factor, or there is a minor, let's say, reversible factor or major reversible factor. The locations of the VTEs, the proximal and the PE, proximal DVT and the pulmonary embolism tend to have a higher risk of recurrence comparison to the distal. Residual venous obstructions, they tend to have a higher risk of VTE recurrence. Males, they tend to have as well, again, a higher risk of recurrence. Age, the younger tend to have a higher risk of recurrence, and obviously they have any risk factors. And the one as well I wanted to highlight is the D-dimer. So using the D-dimer to identify the patients who are at a higher risk of VTE recurrence. This comes from the evidence from prolonged, let's say, investigator, where using the D-dimer as a tool to identify the patients at a higher risk of recurrence. So what found out from this study is patients with unprovoking risk factor. If you do a D-dimer the month before you stop the anticoagulations, and 1 month after, and 3 months after, if you stop the anticoagulation, obviously the one who actually have a negative D-dimer, their risk of recurrence of VTE in the first year tend to be around 5%. While if they're D-dimer positive, for example, a month after stopping anticoagulations or 3 months after, their risk of VTE recurrence goes up to the 10 to 15%. And you might consider, for example, using extended anticoagulation for this group of patients. Again, there has been several validated score. The most, let's say, strongest one, the most popular one, I think, is the DASH score, where you be able to identify if the patients have a higher risk of VTE recurrence, to help you to decide whether you want to stop or stop and reevaluate, or whether you consider continuing anticoagulation after the first score. So that's just give you the recommendation for ESC cardiology, which is 3 months is recommended for all the patients with the pulmonary embolism. If there is a major transit or reversible, then 3 months should be basically sufficient as a duration of anticoagulations. And then indefinite anticoagulations for obviously patients who had a recurrent VTE. So if you have 2 clots, that's basically they require lifelong or long-term anticoagulations. Patients with antiphospholipids, even after their first evidence of first VTE, they will require anticoagulation indefinitely, and that's intended to be with the warfarin. Extending beyond the 3 months, you have to consider for patients when no identifiable risk factors or a persistent, basically, risk factors like cancer and antiphospholipid syndrome. And again, extended anticoagulations if there is no reversible factor identified. If you consider, for example, using the extended anticoagulation for patients after their first clot, you can consider using basically a reduced dose of anticoagulation, like for example, apixaban 2.5 milligram PD or approxiban 10 milligram once daily after the 6 months. As well, very important, which I think we can improve on that, is a follow-up. We need to make sure every patient with a venous thromboembolism, PE or DVT, get followed up on a regular basis to ensure the adherence to the treatment, and as well they should have renal functions, hepatic functions checked on let's say regular intervals, and as well their bleeding risk could be reassessed on a regular basis, especially the patients who commit them to long-term anticoagulation after a first event, because their bleeding risk might change and your balance might change to consider stopping anticoagulations or, as I mentioned to you before, reducing the dose. So these are again the recommendation from the ESC guidelines about the durations of anticoagulations, which again we highlighted reducing the dose can be considered after the first event and after 6 months of a treatment. This is a chart from the ESC again guidelines, just give us the estimated risk. So it's helpful if you want to refer to explain to your patients what's their risk of VT recurrence, whether that's a low, whether it's intermediate, or whether it is high. I've covered that, and it's a short let's say quick overview. So what happened to our patients, the one I've mentioned basically earlier. So she had a CTPA, she had a high Wells score, so no D-dimer. Her CTPA showed a large pulmonary embolism with evidence of RV strain. She was hemodynamically stable, no thrombolysis. She was not hypertensive, stabilized on the low molecular weight heparin, which was followed by DOAC. She was discharged after a few days of observations. She had some alarm, some investigation for trying to identify cause, no cause identified, and she had been followed up in the VTE clinic, and she should have obviously an echo scan as an patients. I think the questions we will do at the end. That's the end of my presentation.
Yeah, thank you, Dr. Hussain, for an excellent presentation, and I hope there will be a lot of questions at the end of the things. And now it's my pleasure to invite the next speaker, Dr. Tariq Bakri. He's a senior consultant in medicine at Sheikh Khalifa Abu Dhabi. So he'll be talking about the advancing anticoagulation in cancer-associated thrombosis. Dr. Tariq Bakri, please.
Good evening. Thank you, Dr. Nias, for the nice introduction, and thank you for everybody to be here. I have a pleasure to be part of this scientific program and talk about very important subject. Dr. Hassanein really did excellent review of the review about VTE, PE in particular, but today I'm going to be presenting the same, but for cancer-associated thrombosis. And we'll go through some of the changes in the guidelines over the last few years, were made now NOAC as one of the options to treat cancer-associated thrombosis. So my objective is three objectives. One, to recognize that VTE is a common complication and it really carries high risk of mortality, morbidity in patients with cancer. Second objective is we know cancer is a major risk factor for VTE, but what about if there is a subgroup who has higher risk of VTE in cancer than the other, and those risk factors should be incorporated at the end with our decision with the patient regarding the type and duration of treatment, and also, as we said, go through the supporting guidelines for NUAC as one of the first line for non-GI cancer-associated thrombosis. So Dr. Hassanein really mentions that VTE is one of the leading cause of deaths worldwide. It carry high mortality and morbidity. Dr. Niaz already in the beginning mentioned that patient, if they survive fatal PE, which is a risk for any patient with the first or recurrent VTE, but they might go into poor life quality of life because of the complication like post-thrombotic syndrome and CTIF in the case of PE. And both of them really bothersome and they reduce quality of life. So our job is really to prevent the VTE to start with, to treat it well, to avoid this, and also to avoid the complication. As you see here, VTE is the second cause of death in patients with cancer. This is a study from outpatient population. You can see the death, number one death is the cancer prognosis, which is 71%. It comes as a second equal between infection and VTE, 9% as a cause of death in cancer patient. And of course, as hospitalized patient, VTE, PE is one of the most common cause of death, even for cancer patients. So what about the burden of cancer-associated thrombosis? What's the VTE risk and what's the natural history of cancer? So you can see that cancer equal hypercoagulable status. So the coagulation system is highly activated in patients living with cancer for multiple reasons. And here are some of the most common mechanisms like venous stasis, damage to the endothelium, expression of the coagulant proteins on the tumor cell surface, and also most importantly, activation inflammatory response, because we know there is a strong association between the inflammation status and the VTE. So we know those are few facts we should really always remember when we talk about cancer-associated thrombosis. It's really common complication, but the good things, it can be prevented and also it can be treated if we diagnosed it early. 15% of cancer with 15% of cancer patients, they have symptomatic VTE, but the alarming and very important to keep in mind that up to 50% of the VTE can be asymptomatic in cancer patient, and the symptoms can be vague. And usually we might pick it up by doing diagnostic scans for any other reason. So it's very important, and this is one of the most important message to take home, that keep cancer-associated thrombosis in your mind when you're treating cancer patient with vague symptoms like vague abdominal pain, other symptoms which not explained by another reason. And we should educate our patient about the risk and the signs and symptoms of VTE. We also know that 10% of idiopathic VTE develop cancer within 2 years. So close follow-up is very important. Does this mean we need to do pan scan for every patient comes with VTE? No, but we need to really look at the history and physical. If there is any high suspicion of cancer, we have to scan the patient. If the patient comes with recurrent idiopathic VTE, bilateral DVT, unusual site, strong family history of cancer, then yes, we might need to do this from the beginning, but not everyone. What things really also make it challenging and concerning for cancer-associated thrombosis, that the patient is already in the highest state of stress. the patient and the caregivers, because the minute we give a diagnosis of cancer to patient, they get anxious, they get overwhelmed. So if the patient develop complication of VTE, that will increase that risk for the patient and the caregiver. And many times, unfortunately, it will delay the treatment, it trigger changes in the cancer treatment regimen, it can prolong hospitalization, it will compromise outcome after surgery as a complication, and definitely surgery will increase the risk of VTE in cancer patients 3 to 5-fold. And this is all carry negative impact of quality of life. While I'm reading the question, if you can answer it, so as we said, cancer by itself increase the risk of VTE, but what about, is there anything else increase that risk even more? So age, stage of cancer, type of chemotherapy, race, central line, few of them or all of them. And the answer, hopefully you got it all right, it's all of the above. And I will explain this in the next few slides. So as we said, you can see the interrupted line as a risk of VT in general population. The minute we give diagnosis of cancer to our patient, the fold goes up 4 folds. That's automatic. Then during the history of the cancer, the risk of VTE goes up and down according to if the patient gets hospitalized, if the patient gets surgery, patient started on chemotherapy, what kind of chemotherapy, if the patient develop metastases. This is all will increase the risk of the patient with cancer regarding VTE. So we can divide the risk factor more into 4 categories. If something related to the patient, so if the patient has multiple comorbidity, if the patient has varicose vein, prior VTE, any other hereditary risk factor, that will put the patient at much higher risk on the top of the risk of the cancer per se. We have a tumor-related factor, so the site or the type of the cancer, we have very high, we have high, all type is really dangerous, but you know, a stomach, pancreas, brain has the highest risk for VTE. Then we have the lung, the hematological, gynecological, renal, bladder. Also the histological grade, so if we have low grade or high grade on the biopsy, stage of cancer and metastasis, you will see in the next few slides, time since cancer diagnosis. So this is all related to the tumor per se. We also have a treatment related, which is what kind of chemotherapy the patient is getting. All of them increase the risk, but some of them much higher. If the patient on hormonal therapy, they go through surgery, radiation, blood transfusion. Most of our patients will have central line to deliver the chemotherapy. That will increase the risk, immobilization, and so on. Also, we have biomarkers, which really sometimes easy for us in our practice to use, like D-dimer. Some of them we don't do in our practice, like P-selectin and MP tissue factor activity. But also we can look at the WBC, the platelet numbers, and so on, because that will play a much higher risk patient. And that's the reason you can see it here. It's included in the Corona model for outpatient for cancer associated to look at the risk of those patients. So you can see the type of cancer. We can see the pre-chemotherapy platelet. If it's above 350,000, it will give 1 point. If the hemoglobin level less than 10 or the patient on erythropoietin, it give 1 unit. Pre-chemotherapy leukocyte count above 11,000, give 1 minute and more. BMI above 35, and depending on the risk, that can be utilized for patient to classify them at much higher risk as outpatient and maybe doing preventive treatment for VTE. We already mentioned the time of the diagnosis of cancer. So all cancer has 4-fold increase, but you can see from 0 to 3 months, it carries the highest risk of VTEs and it starts going down. So it's very important to keep a close monitor, especially in the first few months of diagnosis and maybe up to at least 1 year or so. We also know that the incidence much higher in the elderly for male or female. So that's to keep in mind. And also for recurrence, usually after we treat the recurrence of VTE in cancer-associated thrombosis, it's the highest in the first 6 months, then start going down slowly, but most of the patient will stay at higher risk of recurrence. As we mentioned, the type of cancer is important. You can see the highest goes with pancreatic cancer, brain, AML, stomach, upper GI area, esophageal cancer. Then we have the high risk, which is kidney, lung, ovarian, liver, and so on. Luckily, with prostate and breast cancer, it's high, but not as high as the other, because we see a lot of prostate and breast cancer more than the others. We mentioned about the degree of the dysplasia and also the metastases. So you can see here, if the patient has metastases, the fold goes up 20%. That's really very significant. Also, as we said, surgery increased the risk of VTE about 3.5 to 4%, but specific surgery makes it much more. Gastrectomy, pancreatic cancer, cystectomy, esophageal resection, it carries much higher risk than the rest of the surgery. So those are very important to keep in mind to further classify our risk for the cancer-associated thrombosis. As we said, chemotherapy, any chemotherapy increases the risk of cancer, but in some chemotherapy, it's more. So to summarize this part of the presentation, as we said, cancer by itself carry higher risk of VTE, but we need to keep in mind those factors which might help us to decide about the treatment, the type, and the duration of treatment. So older patient, pancreatic, brain, upper GI, lung, ovarian, lymphoma, cancer, metastatic disease, the first 3 months of the duration after cancer diagnosis, first month after surgery, and specific chemotherapy in particular. So with this, you will see that cancer-associated thrombosis, it was and still a major challenging, but guidelines helping us recently to make it a little bit less challenging in the management part, also for the patients. So you can see, comparing, we're talking about cancer-associated thrombosis, patient with cancer and VTE, they are at higher risk of recurrent after even if they are receiving anticoagulation, they are at higher risk of major bleeding, even more than the people without cancer with VTE. Also higher risk of fatal PE, and also higher risk of major bleed. So that's the reason it's very difficult to treat. We can see that if we have a patient without any risk factor, the risk of mortality, if they have VTE only, it goes 2.6% higher. If they have cancer, go to 7.4. But if we have cancer and VTE, the mortality goes up significantly, 31% fall. So that's the reason very important to do better on primary prevention of VTE in such patient and better secondary treatment. So as we said, those patients with cancer and VTE, they have higher risk of first and recurrent VTE. They are higher risk for major bleeding. They are higher risk of dying. So we really need to balance the risk and benefit. But at the center of all of this is very important to have the patient involved after full detailed explanation, because it's very, very important to have their opinion to treat, because they are the one who's going to take the medication. And you can see here that patient preference and to a degree drug coverage is very important, because if the patient does not take the treatment, it doesn't work. We have to really have a patient preference and cost and coverage in our mind when we decide. And you're gonna hear in the next few, the next part of the presentation, fully informed patient is crucial. So we need to explain the efficacy, the safety, the potential for interaction with chemotherapy and so on. So let's go through the guidelines. We know that before the era of NOAC, many studies showed that low molecular weight heparin, it has better efficacy than warfarin for cancer-associated thrombosis without increase of major bleed. And those are some of the major study played role in the previous guidelines. So you can see all the guidelines before pushing for as first line low molecular weight heparin, and most of the patient with cancer, they need extended anticoagulation. This is very nice article I read, which really reflects our practice on daily basis. I will read it for you. So this one published in 2018 after the initial hope coming from the ASH annual meeting in 2017. So you can read it also. The author wrote, every time, every day, I get a question, is there any pill I can use instead of a needle? And you can see here the guidelines till then, it was recommended for low molecular heparin. We know that maybe the initial phase, the patient will be compliant, but the more the patient stay on those injection, the compliance go down, and especially when they get better from the symptoms, and most of the cancer patient will need long-term. So it's really very not easy for the patient to continue to use injection the majority of the time. And it's really shown in multiple studies that, of course, oral medication in the form of rivaroxaban or warfarin or NOAC, comparing to injections, the compliance, the adherence will stay at higher level, so the success will be higher. Also, part of the patient of the initial NOAC study, which is up to 30,000 patients. Many of those patients, or few of these patients, they had VTE. They were not excluded. And looking at the meta-analysis for those patients, we find that NOAC works as good as warfarin, if not a little bit better on the efficacy, and no increase in major bleeding. So that's the reason where the thought was started, can we use NOAC in the management of cancer-associated thrombosis? Then we had a few direct comparison between NOAC and low molecular weight heparin in the form of the Hokusai VTE cancer trial, which is one of the largest number, above 1,000, using odoxaban. We have the SELECT-D trial, less numbers with rivaroxaban. Then we have also ADAM VTE trial and the Caravaggio trial with apixaban. So with this study, we start getting more information. So also we have the Canvas study, which published in May 21, again, really showing that NOAC is not inferior to low molecular weight heparin from efficacy point. And also in this study, there was no difference in rates of bleeding or death in randomized patients. So I will go through a few guidelines from 2021 till current guidelines. So you can see in the 2021 ASH, American Society of Hematology, looking at the use of NOAC. So in the initial treatment, which usually after diagnosis in the first up to 10 days, they put DUAC or NOAC as low molecular weight heparin as option. They put, of course, apixaban and rivaroxaban because it can be used without the use of low molecular, but still you can use the edoxaban after 5 days of enoxaparin. Then for the short term, which is the primary treatment up to 6 months, they suggest DUAC over low molecular weight heparin over warfarin. And for the long term, also, they put the option of both, and the recommendation most likely to extend the treatment indefinite. Also, they address a couple of areas where we see a lot of incidental VTE or incidental PE and subsegmental PE. Again, the recommendation to treat over observation, especially in the cancer-associated thrombosis. Same for the other unusual sites, the visceral and splenic vein thrombosis. Of course, for central line-associated VTE, the recommendation, if the catheter is still needed and functional and no infection, to keep the catheter. Also, they looked at if the patient failed low molecular heparin, we can go to higher dose, 20 to 30% increase in the dose. And they were really against using filter, even if the patient developed recurrent VTE on low molecular heparin, just because foreign body by itself increase the risk. We have the 2022 International Clinical Practice Guidelines, which almost gives the same recommendation. So in the initial treatment, up to 10 days, we have the two options, low molecular weight heparin and NOAC. And here the guidelines start really differentiating a little bit more GI cancer or genitourinary cancer versus none, because the GI cancer and genitourinary cancer has a little bit more higher risk of bleeding when we use NOAC, because it's more membranous mucosal membrane cancer. Same for the long term, they give the same option and also recommendation to at least give 6 months of treatment, and we'll talk about the duration a little bit more. So for the newest guidelines, we can see that, and just I need to move the here. So the ASCO 23, you can see again, initial anticoagulation, giving the two options of the low molecular weight heparin and the NOAC, but also they put a caution with direct factor 10 activity inhibitor in the form if the patient has a GI or genitourinary malignancy. Also to keep in mind other setting which can cause high risk of mucosal bleeding. So the type of chemotherapy needs to be really looked at, and also drug-drug interaction. So it's very important to keep all of this in mind when we're treating CAT. So also for the duration, the recommendation to extend more than 6 months and most likely for life in patient who has active cancer, who has metastatic cancer, receiving chemotherapy. And we have to always, as Dr. Hossein, re-evaluate the benefit risk of the efficacy and the bleeding risk every few months, because this is dynamic situation. In NCCN, and I'm almost done with the presentation, so just bear with me for a few more slides. So NCCN 2020, and now we have the 2023. I will show you both. This is very guidelines really followed by the majority of the oncologists also. You can see that from 2020, they start talking about NOAC as category 1 in the form of edoxaban and abexiban as a preferred over low molecular weight heparin for patients without GI malignancy. And of course, taking case by case, taking the patient preference after looking at the whole concept, as we said, the efficacy, the bleeding, the renal, the hepatic function, drug-drug interactions, the type of chemotherapy, and the course, and so on. And of course, in the form of low molecular weight heparin, they prefer dalteparin because most of the study is for dalteparin, also as category 1 for GI cancer. In 2023, and I made it bigger, again, here you can see, and here in 2023, it was more precise terminology, where they say without gastric or gastroesophageal lesions, because the risk of the GI bleeding with NOAC increase in the upper GI cancer much higher than the lower in the colon. So here they say basically NOAC or DOAC without gastric or gastroesophageal lesion, They put apixaban, edoxaban as category 1, rivaroxaban as category 2A, and also they kept low molecular weight heparin as category 1 for the gastric or esophageal lesion. So this is something to keep in mind when we decide about the treatment. They also added, if for some reason we give the NOAC for those gastric and gastroesophageal lesion or malignancy, if we're going to use NOAC, they put apixaban may be safer than edoxaban or rivaroxaban, but it's category 2B. And Dr. Hassanein mentioned the European Society of Cardiology risk categorization risk factor. So you can see cancer is in the high risk group, where most of the time, if there is no really contraindication, the anticoagulation should be extended. Also, in some cases, we might need to discuss with the patient that we might not give anticoagulation, and you can see a few lists here. So if the patient non-acceptance, so the patient doesn't want to be on anticoagulation after full explanation, if there is no therapeutic advantage, if the especially limited survival, high risk for bleeding, no planned oncological intervention, and just palliative treatment. But also in the palliative group, if there is no benefit of the such like elevating dyspnea, preventing leg swelling, and so on. And of course, an unreasonable burden of anticoagulation, like painful injection, frequent monitoring with phlebotomy, and if it's not going to make a difference in the outcome of the patient. In 2023, this is published or and actually presented in the European Society of Cardiology 23. This is a study done on comparison edoxaban without for extended treatment. So they took patient with isolated distal DVT and they treated with edoxaban 3 months versus 12 months, about 600 patients. The primary endpoint was looking at symptomatic recurrent of VTE or VTE-related deaths at 12 months, comparing with 3 months. And also as a secondary endpoint, they looked at major bleeding because it's always important to balance the benefit and risk. And you can see here that there was really significant reduction in the primary endpoint, 7.2% in the patient with the 3 months versus 1% for patient extended to 12 months. And the major bleeding was slightly elevated more for 12 months than 3 months, but it was not statistical significant. So the conclusion was, and it was the first study looking at isolated distal DVT for extended up to 12 months, that edoxaban was superior 12 months over 3 months in respect to less recurrence, less or VT-related deaths, and no difference in the rate of major bleeding. And it's always good to mention here for isolated distal DVT in non-cancer patients, there is an option of not to treat and to do serial Dopplers, and if the patient does not develop more symptoms or prolongation of the clot, to really not to treat. But in cancer, it's always recommended to treat. So this is big list of, as we said, chemotherapy, and some of them, they have really high risk for GI toxicity and stomatitis, erosions, and so on. So those needs to be kept in mind, not only upper GI or non-GI cancer. The type of chemotherapy which can cause GI toxicity is very important. Of course, the drug-drug interaction is important for cancer and non-cancer VTE, and you can see big list. So that's the reason a clinical pharmacist is has very important role when we take a decision, because as a physician, we cannot really keep up with all these interactions. Finally, I will mention also regarding drug-drug interaction to really try to help us to decide which NOAC to use comparing with others. This is from the European Respiratory Review in 2022. They looked at non-small cell lung cancer, and they used of a small molecular inhibitors and NOAC. And you can see here the conclusion. It was with edoxaban, most of the time there was no interaction, and there is no need to really reduce the dose or space the medication from other chemotherapy. While using the other anticoagulation, sometimes up to 10% of the cases, we have to either reduce the dose or space the treatment, which really always make it more challenging. So usually the lowest drug-drug interaction in some patient or some chemotherapy is much easier for us. So you can see here the table, and again, it's very difficult to really read all of the medication, but you can see just by the color, edoxaban mostly has yellow, which is really much less drug-drug interaction. Apixaban comes next with a few precautions where you have to reduce the dose either 25 or 50% with specific molecules. Dabigatran has also a little bit of recommendation if used to really space the dosage. And usually the dabigatran in the guidelines, I didn't mention it earlier, it really comes as alternative NOAC treatment. So usually apixaban comes first, rivaroxaban comes second. And I think part of the rivaroxaban you can see is mostly red regarding drug-drug interaction. Again, here, same in different way. You can see more green in the edoxaban comparing with the other NOAC. So just always look at the type of chemotherapy, look at the drug-drug interaction. Clinical pharmacists are the best people to help us with this when we take the decision. Finally, there are a few future study. One study, they are looking at, population with atrial fibrillation and VTE, and the real life incidence of VTE or hemorrhagic complication by not excluding cancer patients from those single center observational study. We also, apixaban, they are looking at reduced dose 2.5 BID after the 6 months primary treatment in cancer patient, because till now, basically apixaban and rivaroxaban, they have the indication to reduce the dose after the primary treatment 6 months, but not for really the high patients, the high-risk patients like cancer patients. So this one will help if it's positive to see if after 6 months with cancer, and if you utilize apixaban, you can go the 2.5. Finally, Dr. Hassanein mentioned we have multiple NOAC or DUAC. All of them really very good medication. All of them works very well. Minor differences between some of them, but I put on the right side some of the list really I keep in mind when I choose NOAC I'm using for a specific patient. So I take it case by case. I get the patient involved. So you can see that once a day versus twice a day. So it's very important to ask the patient not to take a decision on the patient if he will be able to take twice a day and maintain twice a day, because if not, the risk of recurrent will increase. Dr. Hassanein mentioned about rivaroxaban needs to be taken with a meal and with the heaviest meal, and advised more fatty intake for bioavailability. The cost is very important, as you see in one of the slides, the insurance coverage and cost. Edoxaban in our area give a little bit advantage on the cost. Drug-drug interaction, as I showed you, is very important. Edoxaban has a little bit more edge in that area. Reduced dose as part of the trial. The only NOAC edoxaban study for atrial fibrillation and VTE, it was part of the study to reduce dose according to the weight the creatinine clearance, and a drug-drug interaction. The severity of the VTE without initial low molecular, as we said, Dr. Hassanein mentioned that in some NUAC, they utilized a higher, the population was much more severe than the other, like in the Huxley trial. Renal function, of course, and at the end, as we said, a preference of the patient. They should be the center point of our discussion. So to conclude, basically, as you see, cancer is a very risk for VTE. There are some subgroup at higher risk than the other. I hopefully mentioned all of them, and those should be part of the decision making after we explain to the patient fully the benefits, the risks, the interaction, and so on. It should be multidisciplinary decision, including the primary care or IM or hospitalist, thrombosis specialist if available, or hematologist, patient oncologist, clinical pharmacist has big role, as you saw, because drug-drug interaction and the type of chemotherapy, GI toxicity is very important. But in summary, basically now you can see that NUAC is one of the preferred one after looking at all the facts we talked about it, especially for non-GI cancer, and in particular the upper GI cancer versus low molecular heparin versus warfarin. Thank you very much.
Thank you very much, Dr. Tariq Bakri, for a very comprehensive and very nice coverage of the topic. Now we've got some questions, in fact, 10, 12 questions in the chat box, and we've got only 15 minutes, I think 15 to 20 minutes. So I think I'll straight away. I wanted myself few questions and few things to be discussed, but I think we should give chance to the audience. So I just go through the questions. Let me just, yeah. Okay, so they're asking about the slides. Okay, it is not available. Can dialysis remove it? So anyone can answer. Anyone of the speaker?
I think, I don't know, it's not clear, but I mean, the bigatran usually, can be removed by the dialysis because it's mostly secreted by the kidney. But for the rest, we have the antidote. Even for the bigatran, we have the antidote. But for dialysis in particular, I know the bigatran, you can use dialysis as part of the removal, but not the rest. Dr. Hassanein, any?
Completely. I assume this is in the context of, for example, a need of immediate removal of or giving an antidote for the anticoagulation for a bleeding risk or for immediate operations. Or yes, there is the antidote for dabigatran, there is the idarzumab, and the antidote as well for factor 10A is as well available, although it's very expensive at the excellence, basically. So there are antidotes available without a requirement of the hemodialysis, if that's what meant by the questions, basically. i.e. reversible agents. And obviously it all depends on the reason of trying to reverse. Is it the patient's having a major bleeding? But the dialysis tend to be mainly, as Dr. Bakri suggested, if required for dabigatran. I think the others, even for dabigatran, there is the antidote.
Yeah, I think from practical point of view, I think dialysis may not be feasible because patient, if someone has got already overdose, and then hemodialysis itself becomes a risky procedure for bleeding this thing. So I doubt it will be practically possible to send the patient for dialysis. Okay. I don't think any nephrologist will agree with me just to remove their things. Okay. But theoretically, you are right. It is possible to remove some of the dabigatran by the hemodialysis. Yeah. So, okay.
And just regarding the antidote, it's very nice to have the antidote, but to be honest with you, and maybe Dr. Hassanein will agree, in our practice, we're really hardly using the antidote because most of the patient, we can control them in other way. And NUAC, to start with, cause less major bleed than the others. And most of the time, depending on the renal function and depending on the timing of the last dose. So really in our practice, in the last year or so, I had 1 or 2 patients we we thought about antidote, but at the end, after talking to clinical pharmacists and so on, we found that it will not be very, very helpful because the time after the dosing was really higher, yeah, more than what we're supposed to.
Yeah. I mean, I remember 1 or 2 cases of massive ICH, and we were able to give antidote in a time. But as you mentioned, clinically, I mean, it's very rare generally. The fear is more than the reality, you know. I mean, generally, these drugs are very, very safer, you know. Okay, one more question is there loading dose or bridging needed for dogs? I think Dr. Tariq already mentioned in his last slides the dosage scheme for all the different dogs. The another one is they're asking about the side effects for anticoagulation therapy. Is it similar between normal patients and cancerous patients, Dr. Tariq?
So as we mentioned, it's different because cancer patient, they will be on chemotherapy. So you really need to have a clinical pharmacist or dig deep in to look at the type of chemotherapy, the drug-drug interaction, and so on. But overall, cancer patient, as I mentioned, automatically they are at higher risk of major bleeding, at higher risk of death, comparing with non-cancer patient. But you have to be very careful to look at what's the best medication you're going to give, looking at the patient profile and the interaction.
I think there's another question related to the PE cancers. I think one of Dr. asked, symptoms and signs of PE in cancer patients are different from normal. I think we have already discussed, I think, and what about this diagnosis of cancer, diagnosis of PE in patients with cancer because of the overlapping shadows and these things? I think
I think the
CTPA will be able
process,
to.
yeah, the process, I think it's exactly the same. Just you need to have high suspicion. You can use the Wills score and so on. There is no difference. Dr. Hassanein?
Yeah, it's the same. CTPA, the same should be diagnostic enough in terms of a tool of investigation, basically.
Yeah.
And as I mentioned, I think with cancer associated thrombosis, and I think that will answer the previous question, there are some patients who comes with vague symptoms. They are not that symptomatic, and you might pick up incidental PE or subsegmental PE, which sometimes in other patients you might not treat, but with cancer, it's recommended to treat.
Yeah. So another question is in renal or hepatic patients, is the loading dose needed for dogs? So maybe Dr.
In who, sorry? In
Hasnain?
renal? In renal?
Renal or hepatic patients, is there any need for loading dose?
So all of
Dogs?
them for a VT, all of them will be loading depending on which DOAC you use. So basically for rituximab, for example, you will use 15 milligram twice a day for 3 weeks, followed by 20 milligram once daily. For edoxipam, you need 5 days of low molecular weight heparins. Then obviously you go on 60 or 30 milligram depending on the weight. So if that's what meant for apixaban, it's 10 milligram twice a day for 7 days. Then after that would be 5 milligrams twice a day. So there is dosing regime for each of the DOACs basically, but there is no difference to whether the patients is if they have obviously normal renal functions or they have a bit of abnormality in the liver function, they will still need to have the same doses if you're using these anticoagulation.
Yeah,
obviously for renal patients, depending on the EGFR, on the creatinine clearance. So if their creatinine clearance less than 30, you might not be able to use statins. Less than 15 is most of the DOACs is better to avoid. That's for the renal cases. 50 to 30 you can use, for example, apixaban, but still the doses is basically the same in terms of the loading. I don't know.
I think I need to emphasize the same as Dr. Hussein said, because this is something we see really frequently in our practice. The dosage for the NOAC is completely for VTE different than the dosage for atrial fibrillation, because many of the practitioners, they use the criteria for atrial fibrillation on VTE. Actually, there should be no renal dose adjustment. There is no really study to support it. So just, we need to be careful to use the appropriate dose. And as Dr. Hussein said, the majority we can go down to 15, but you have to be careful.
Hepatic case is the same, basically, depending on which degree of cirrhosis they have. If they have let's say, severe degree of cirrhosis, you might avoid using DOACs anyway because of the risk of bleeding. It might be safer to use alternatives. Again, depending on the what's the degree of their hepatic disease. A mild form of liver disease, normally you don't need any adjustment, basically.
Like
Yeah,
child
tricky
A and
situation
B,
is, sorry, tricky
like
situation
child
is,
A, B,
when
and D
patient
is
has got
fine.
sorry, tricky situation is when the patient has got cirrhosis as well as portal vein thrombosis. So then they might have already liver impaired enzymes and zynar. So this is a very tricky situation. No? Patients portal vein
Absolutely
thrombosis.
right. Exactly. These are very, very challenging cases, basically to do. Again, depending on the individual patients, depending on their platelets. So, for example, if they have an already underlying very low platelet with thrombocytopenia less than 50 or even less than 30, you might avoid the low molecular weight heparin, or you might accept using a reduced modified dose of the anticoagulation, so a reduced dose on balance of the risk and benefits. Or you might choose as well even a low molecular weight heparin at a reduced dose for patients with advanced liver disease with thrombocytopenia. Very difficult and challenging case. These cases as well, you would have to consider, for example, in cirrhosis patients with the esophageal varices, you might screen them from beginning with an OGD to see if there is esophageal varices to ban them before the anticoagulations.
Yeah, but I think sometimes, we have, because even the junior docs ask, and one has to be very sure what is the cause of thrombocytopenia and cirrhosis. Because if it is a massive splenomegaly, hypersplenism, so these patients, they do not bleed generally, at the, so you have to be sure whether just low platelet count, is it because of the sequestration in the big spleen, or is it because of PLE2 itself? So in that way, I think the esophageal varices has to be very much ruled out, because so platelet alone count cannot be really the decisive factor in selection. Of course, if it is around 70, 80 above, I don't mind it. But if less than 70, 80, perhaps we have to be very careful.
Yeah.
Isn't it? Yeah. One more thing, I think questions we don't have. Yeah, let me see any other question is there. Before I find any question, just one clinical question, because I don't know, I want your experience, because we have seen quite a good number of the patients who are already on NOACs. I should not name any particular NOACs here. They come with another thromboembolic events. They have been, if you ask them, they have been good compliance, regularly taking medication. So what do you do in these patients? I think Dr. Tariq mentioned about, maybe you mentioned some others, right? Should we increase the dose or should we switch to different NOACs? What is, I want both of your opinion, It's a tricky situation again, but
Well, Shall I start, Dr. Tariq, or do you want me to
Yes,
talk?
go ahead. Go ahead.
Okay. So my approach to these cases, after obviously the first things which you've highlighted, is one, establishing that they are compliant with the dose, they are compliant with how they are taking it. So, for example, the ribroximab, as we said, with food, and so they're compliant with the dose. If they are fully compliant with those, I look at if there is any individual patients-related factors. So, is the patients, for example, very, very obese with weighted over 40 or over 140 or over 150, which we know we should not basically use DOACs in certain situations. So if I've excluded all of that, and I'm sure this is a failure of DOAC as an anticoagulant, the patient developed another clot, I tend first to switch them obviously to low molecular weight heparins. Then we'll discuss with them either keeping them on the low molecular weight heparins, keep them on low molecular weight heparin at least for anticoagulating them at least for 4 weeks, then switching them to warfarin if they agree. That's my intent, my approach. I think switching between different DOACs, I don't see there is any much of that's my practice. Obviously, this is all based on basically, let's say, individual practice. But my practice, if I establish the patients, there is no reason they are compliant, they're taking it on a regular basis, I rule out any patient-related factor, like, for example, cancer, or any reason for them to have a persistent basically clot. And if I excluded all of that, and I'm sure this is a medications basically related factor that they have not been anticoagulated, then I tend to either low molecular weight heparins, giving them for a longer duration of low molecular weight heparin, then warfarin if they agree, or at least keeping them for the acute stage a good duration of low molecular weight heparin. And if they don't agree to switch to warfarin, then switching them to a different type of anticoagulant of DOACs basically.
So I think he covered, Dr. Hassanein covered all of them. Just I will add a couple of things. One of them, I think, of course, the compliance one said, but apixaban, I had a few cases where really you need to go deep with the patient, and some of them for cost issue, I found that they are dropping twice a day to once a day, and they think they are really doing the right thing. So this is one of the issue always I address also with the patient. As Dr. Hassanein said, basically, like rule out cancer, maybe new things going on with the patient, hypercoagulability, maybe antiphospholipid if it's not checked before, especially the positive triple antibodies. And also, I think as Dr. Hassanein, most of the guidelines really recommend to switch to low molecular heparin for 4 weeks, then either go to warfarin if possible, continue low molecular if possible, or change another one. What I will say, and Dr. Hassanein, maybe I don't know if you like, if you do this, maybe switching the anti-factor 10 to مثلا to different, like dabigatran, which is thrombin, direct thrombin inhibitor. So changing the mechanism might. I mean, there no evidence-based medicine on this. It's if somebody of low molecular heparin, I think the recommendation, if they are taking once a day, to go to the twice a day, and if they are on the twice a day, to go 20 to 30% on the dose.
Yeah, but what about, I mean, I have got a few patients sometimes, they get medicines from different parts of the world. So a lot of generics are available also. So I don't know, there's no comparison of bioavailability, but this may be not very big factor, but that may be also contributing some of the patients, So this is
very important to keep it in mind.
Yeah, especially with some rivaroxaban and these kind of things, which are more related to the meats and these things. Now, one more thing I want to ask.
Yeah,
from
but
Dr.
the other thing, Shah, I would just as well to highlight is that it is sometimes I get asked by trainees or residents about increasing the current dose beyond the doses which has been recommended. This is against basically using it in SPC. So there is no evidence suggests you increase the dose of for example, rivaroxaban or edoxaban or apixaban beyond what has been licensed if the patient developed another VTE. So that's not to consider at all.
I will add, it's good you mentioned it, Dr. Hassanein, because if the patient goes into reduced dose, like, in the 10 milligram rivaroxaban and 2.5 BID apixaban, I think that's, we should go back to the full dose.
Yes, exactly.
Yeah. I think there's not much more questions now. One more thing before we wind up the session. Now, Dr. Hassanein, you mentioned about the acute thrombolytic therapy, but another important thing one has to realize that these guidelines, when they portray the things, they are thinking of an ideal world. Although some of the guidelines, they are trying to cover a lot of clinical scenarios, but being we in the real world, we see sometimes the real world is very different. You understand, isn't it? Now these, let us say, person with pulmonary embolism who has got a intermediate risk, okay? His hemodynamic stable now, or maybe is a little bit high troponin and maybe RV strain is there, but he's hemodynamic stable now, okay? Now, we start with either heparin, which personally I do not like it because I am talking of the unfortunate, because once you keep the patient on the heparin, you need to monitor the PT, and it's very difficult to follow in real, because you'll always lagging behind or chasing the PTs, and so you never be achieving the therapeutic range of their things. That is a practical thing. Another important thing is, let us say same patients deteriorates after 12 hours or 24 hours, okay? So now we have got a cutoff window, for example, golden window period for thrombolysis in stroke patients, but we do not have any specific, and people can do thrombolysis in second or third either. So what is your opinion, and how do you manage these kind of the patients,
So basically, I completely agree. Obviously, the low molecular weight heparin is much more easier, more more convenient nursing staff. You don't need the monitor. You achieve therapeutic basically targets in all the patients when you give the patients. In selected patients, a majority of patients admitted should be on the therapeutic low molecular heparin instead of unfractionated heparin. I think when I mention unfractionated heparin, it's only for a very, very small percentage. That's the one who are not, let's say, in a hemodynamic compromise, but they tick all the boxes that they might be at extremely high risk that you might consider for them thrombolysis. So very tachycardic, hypoxic, positive troponin, positive BMP, RV strains on the echo, but they are still yet hemodynamically stable. So in this case, you might consider better to be HDU, but better using infractionated heparin in case that you are planning, let's say thrombolysis. Now, for other group of patients that you started them on the low molecular weight heparins and they become a compromise, then they went to shock. Again, the guidelines is basically you thrombolize them. You thrombolize them irrespective of the timing of the low molecular weight heparins. Now you might not give them a bolus of low molecular weight of the unfractionated heparins. You might obviously still check the APTT and decide of the dose of the unfractionated heparins after. That's let's say my practice. I don't know what you think, Dr. Bakri. What's your opinion?
I think I agree 100%. And there is no window actually for the PE. Usually the best within 24 to 48 hours, but still can be done up to 14 days. And I will add with the unfractionated, sometimes those patients who's very, very unstable with the renal function less than 30, they prefer the unfractionated heparin. Although we have always trouble, as we said, with the PTT and so on. And even actually now, most of the people, they really look at the anti-factor 10 monitoring instead of the PTT.
Yeah.
The other point I thought as well to highlight is these patients with intermediate, let's say intermediate risk PE, their highest risk of deteriorations tend to be the first 5 days. So they can deteriorate anytime during these 5 days. The most highest is basically the first 72 hours. So as a minimum, we need to observe them between 3 to 5 days. That's why it would be the safest things is I would not intend to be my practice is intend to keep them on the low molecular weight heparins, not to switch them to any DOACs too prematurely while they are in patients. Whatever decisions I'm using as what agent I'm going to use, but for example, if they are high intermediate, I don't start them on rivaroxaban as an inpatient. I just observe them on the rivaroxaban as an inpatient. I think this is too high risk approach, especially if they have a very high, very large basically PE if they're hemodynamically stable. I keep them only on the low molecular weight heparins, monitor them for a few days. Then I switch them to whatever, let's say, DOACs and whatever agent I'm going to use.
I think that's the reason in the design of the HOXI, where really one of the reasons why they give 5 days is because they are higher risk patient. And also because they cannot go right away with NOAC.
Yeah. The another thing which I like about the heparin, I'm talking of the low molecular weight heparin. The earlier study, you remember they were suggesting, it was not proven later on, that the heparin itself might have some anti-inflammatory effect also.
Yeah.
So especially stabilizing these. So although we are not highlighting it much, but frankly, it sounds very interesting and more convincing to use a low molecular weight heparin for at least few days till we go for genoacs. But I don't know, what is your take on this thing?
I think it's not only the anti-inflammatory, the vasodilation effect also. Yeah, so both, but I think some of the people will like it for the vasodilatory effect initially also. But I think Dr. Hassanin, he put it very nicely, said, people at moderate and high, it's not recommended to start right away. We're talking PE. It's better to go with at least a few days of enoxaparin, then go with whatever you want. And it's part of the European Society Cardiology. They tell you, according to the score, index score, 1 and 2, you might go right away. 3 and above, always go with low molecular heparin, then switch.
There's one question actually from, they're asking about the splenic vein thrombosis. That what is the logic of observing these patients and not treating similarly in catheter vein thrombosis also? Why not to be treated? Why just to
With
be,
cancer or without cancer?
uh, I think they haven't mentioned, but probably they mean in the cancer patients. Yeah.
Actually, Dr. Hassanein did nice presentation last year in the Emirates Society regarding the unusual site. So, Dr. Hassanein.
So that's without cancer or that's with cancer?
I think let us say with cancer maybe. Yeah, thinking.
I think with
Splenic vein thrombosis.
cancer, yeah, I think with cancer, as we mentioned, similar to incidental PE, subsegmental, distal DVT, since cancer is there and the patient is at low risk or low to moderate risk of bleed, is better to treat.
I think so.
Yes,
If in
doctor.
cases of without cancer, symptomatic, they intend to be needing to be treated. Now, the one who are certain groups that you might not consider anticoagulations, if you have a very, very clear cause, for example, patients with diverticulitis and nearer that they have a splenic and they might have a higher risk of a bleeding, then you might treat. But otherwise, majority of the cases they would need to be considered treatments.
So I think we have already passed 5 minutes past the allotted time. So we had a very wonderful discussion and VT topics, such interesting that we can carry on and discussing many aspects. So I think we might have to wind up. Thank you very much, both of the speaker, for their wonderful participation and input. And of course, we have got quite a large number of audience, around 160, 170 people who are attending it. So thank you, Dr. Hassanein, and thank you, Dr. Tariq Bakri. And I would like to thank the Emirates Society of Internal Medicine for arranging this webinar. So thank you very much, Dr. All the participants also, they have been still with us for a last 2 hours nearly so. And thank you, Mohammad Janedi, for arranging all of the things.
Thank you very
much. See you.
Thank you very much.
In this.
Thank you.
Yeah, thank you.